Hello, everyone. We're just going to give a couple seconds here for people to connect, but thank you for joining us. Hello, everyone, and welcome to our ISPCAN Monthly Journal Club. My name is Jane Estes, and I'm the Knowledge and Content Development Manager for ISPCAN. ISPCAN's monthly international journal clubs are always free of charge and cover diverse research topics, which are presented by subject matter experts from around the globe. These 90-minute webinars are designed to help our members and partners in the ISPCAN community gain access to knowledge and expertise to inform care, improve practice, and drive policy change. All this is critical to help improve outcomes for children globally. And because we believe that you should have access to all the information and resources available to support you in your work, we encourage you to visit the ISPCAN Knowledge Hub. The Knowledge Hub is an open access centralized library containing ISPCAN and critical member and partner resources. This collection of resources can be searched by critical topic, author, presenter, or type of resource, and is organized with all supplemental materials and links attached to make it very user-friendly. If you have an open access resource that you would like highlighted in the ISPCAN Knowledge Hub, please email me at partnerships@ispcan.org. Today we'll be covering the special issue journal, Epidemiology Risk Factors and Impacts of Adverse Childhood Experiences in Low and Middle Income Countries. The tips for making the most of today's session, just please engage with us. This session is meant to be an active, interactive learning platform. Please participate by sharing your comments in the chat and your questions in the Q&A box throughout the webinar. We will access the Q&A box at the beginning of the panel discussion, so having the questions ready is very helpful. Also, please take a moment to introduce yourself to other attendees, our moderators, our featured presenters, and the chat box. Please let us know where you're joining from, your organization, and your discipline. To enhance your experience, you may enable closed captioning from your Zoom control bar by choosing Captions. And as always, for joining us today, a recording of this session, the panel discussion, presentation slides, and links to featured resources will be sent to you after the webinar. Our key learning objectives for today's session is to gain a more comprehensive understanding of the adversities faced by children and young adults living in low and middle income countries, and to highlight some of the gaps in ACE's research with respect to the inclusion of children and youth residing in these countries. Also, to gain insight into the background of the Special Issue Journal, specifically why it was focused on low and middle income countries, and why it was focused on children and youth. We will cover and highlight the critical findings that were in the studies of the Special Issue Journal. We'll look at the African study, the Asian study, and the Latin American study. We'll also examine cross-cutting themes that emerged throughout the research contained in the Special Issue Journal. And now to meet our presenters. Dr. Leah Gilbert, who is a Special Issue guest editor. Dr. Gilbert earned her medical degree and Master's of Science in Public Health and Maternal and Child Health and her Bachelor's in Psychology at the University of North Carolina, Chapel Hill. Leah has a long history of research and activism in the prevention of violence against women and children, both domestically and globally. After training as an emergency medicine physician, she joined the CDC as an Epidemic Intelligence Service Officer. After completing the AS program, she served as medical officer and subject matter expert in intimate partner violence, child maltreatment, and adverse childhood experiences for the Division of Violence Prevention at the National Center for Injury Prevention and Control. After 10 years at the CDC, she joined the National Institute of Health as a program officer. And Dr. Shante Dubé, also a Special Issue guest editor. Dr. Dubé is professor and director of the MPH program at Levine College of Health Sciences at Wingate University. Shante received an NPH in epidemiology from the George Washington University in Washington, D.C., and a PhD in behavioral health from the University of Georgia's College of Public Health. In 1999, she joined the CDC as a preventive medicine fellow and served as one of the early investigators on the landmark CDC Kaiser ACEs study, leading to CDC awards for scientific excellence and international recognition. Shanta has led and engaged in various global initiatives related to ACEs science, trauma-informed care, and substance use disorders. She has over 130 publications and is the associate editor for Child Abuse and Neglect, the International Journal. And Dr. Frances Anor. Dr. Anor is lead epidemiologist with the US CDC Division of Violence Prevention. Frances provides leadership on data analysis and programming of the Violence Against Children and Youth surveys. His research focuses on violence, risk factors, and consequences of violence against children and youth. He is also a special issue guest editor. And Covette Brown. Covette Brown is a research fellow in the Division of Violence Prevention at the CDC. She's worked on the Global Violence Against Children and Youth surveys in Sub-Saharan Africa and the Caribbean, and she is currently working on special projects that guide the first adaptation of the Global VAC surveys in the US. Covette's research interest is using evidence-based data to guide interventions aimed at preventing violence against children. And now it's my honor to turn the session over to our presenters.
All right, I'm very happy to be here and connect with you all today. So thank you for attending. And as Jane mentioned, we'll be discussing our special issue in child abuse and neglect, epidemiology, risk factors, and impacts of adverse child experiences in low and middle income countries. And I am Leah Gilbert, and I oversee the research portfolio on all forms of violence affecting children at the NIH. Next slide. So I think most of our audience here is familiar with adverse childhood experiences, but in case you have not heard of the terminology, ACEs are potentially traumatic experiences that undermine a child's sense of safety, stability, and caregiver bonding. What we know is that ACEs tend to co-occur together. They can result in toxic stress, and they are associated with a wide range of adverse behavioral, health, and social outcomes. And I've pulled these ACEs up here because these are the most traditionally studied ACEs. They tend to center around abuse and neglect or dysfunction or stress within the household, such as living with a family member who might be incarcerated, experiencing parental separation or divorce, witnessing interpersonal violence in the home, or living with someone who's experienced alcoholism, drug abuse, or mental illness. And I think it's important to mention these specific ACEs because they tend to cluster around things that occur within the household. Our most commonly studied ACEs are less focused on adversities that occur in other settings, such as peers at school and intimate relationships or in the community. Next slide. And ACEs have really gained such a following in the literature because we know they have such an impact across the lifespan. We know that ACEs fundamentally alter the developmental trajectory of the growing child, creating enduring effects across the lifespan. And this pyramid shows how those mechanisms might work, starting from even genetic transmission of intergenerational trauma to then the child being born in whatever local conditions and context that they live in, and then experiencing ACEs themselves. We know it begins with disrupting neurodevelopment, altering social emotional learning, and all of this results as the child gets older. Perhaps they're engaging in high-risk behaviors that then later expose them to disease and disability, and in the worst-case scenario, early mortality. Next slide. The term cumulative childhood adversity is just another way to talk about how many adversities or ACEs that one has experienced. And I think ACEs have been so popular in the literature because it's very visually easy to understand. We've noted time and again this dose-response relationship whereby as the number of ACEs experienced increase, so does the risk of various health outcomes, 40 plus to date, and still growing as we study different forms of health outcomes that children have experienced. Next slide. And despite this huge following and body of research within ACEs, we know there are some significant gaps. I think an important one to mention is that the majority of ACEs research includes adults as participants. And there's a few issues with this. The first might be recall bias. So when we're asking older adults to remember their experiences before 18, there could be memory issues or even suppression issues if they've experienced significant trauma. Another issue is that we're gaining a dated understanding of adversity. So if we're asking, 40, 50, 60-year-olds about what happened back when they were 18, it's not a contemporary vision of what youth are facing today. And then, of course, the older the participant is when we ask, the less opportunity there is to intervene. So we want interventions that are proximal to the experience and then applicable to the types of adversities that youth are experiencing today. A second major gap is that the majority of ACEs research has originated in high-income countries. And this has a couple of issues as well. We know that there is a variety of adversity that youth experience, and those ACEs that I mentioned on the first slide are just some of them. We know that in low and middle income countries that youth are experiencing adversity that might be different or more common compared to high-income countries, such as poverty, orphanhood, food insecurity, collective violence, human rights violations, just to name a few. So we really need to expand our understanding of the types of adversity that youth are facing. A second issue is that high-income countries are not representative of the majority of the children's population. Most youth reside in low and middle income countries. And then low and middle income countries might offer us some better understanding of protective factors and resilience. There are things we could learn from some of the things going on in low and middle income countries that might help, such as stronger social support systems, collectivist culture, intergenerational living, etc. Next slide. So those two major gaps that I mentioned, the fact that most studies involve adults and that most studies have originated in high-income countries is what led to the birth of this special issue. So we specifically requested that the papers involve youth specifically up to age 24 and that the youth reside in a lower and middle income country. Other than those two major criteria, we welcomed a breadth of research types, as you see here. Next slide. And what resulted from this special issue were 16 manuscripts representing 9 countries. From the Latin American region, we have studies from Mexico, Colombia, and Brazil. From the African region, we have studies from Kenya, Mozambique, Namibia, Cote d'Ivoire, and Lesotho. And from Asia, we have 2 studies from China. And as we present our results today, we're going to be presenting by region just as a way to organize our findings. Next slide. And I will now pass off the presentation to Dr. Anwar.
Thank you, Leah. Good morning, good afternoon, everyone. My name is Francis Anwar, and I'm a lead epidemiologist here at CDC. I'm going to be walking you through the findings from the African studies. Next slide, please. So as Leah had already mentioned, 9 out of the 16 studies that were included in this special issue utilized data from Africa. And each of these 9 studies used data from the Violence Against Children and Youth Survey, or the VAX. 7 of the 9 studies used pooled VAX data from 5 countries, 1 used pooled data from 4 countries, and 1 used data from 1 country. Next slide. Given that all African studies use data from the VAX, I'm going to be giving you a little overview of the VAX. Next slide. The VAX is a nationally representative household surveys of males and females ages 13 through 24. It uses 3-stage cluster survey sample design and has been implemented in over 23 jurisdictions as of the end of 2023. And they are led by country governments with technical support from the US Centers for Disease Control and Prevention, CDC. The VAX receives significant funding from the President Emergency Plan for AIDS Relief, or the PEPFAR, as well as funding from the United States Agency for International Development, USAID, and in some jurisdictions, the United Nations Children's Fund, UNICEF. VACs have also been supported by Together for Girls, a global partnership working on to end violence against children and youth that includes national governments, United Nations entities, US government agencies, the private sector, and civil society. Whereas the CDC provides technical support to countries implementing the VACs, the actual implementation is carried out by in-country institutions. To maximize disclosure and to ensure participant safety, the VACs provides extensive training to field staff. And the VACs has also collected HIV-related data, including risk and protective factors, and has also offered HIV testing in some jurisdictions. Additionally, human subject protections are also built into the study, including free direct and accessible social welfare services to all participants who may need it during the survey. Next slide. These are the objectives of the VACs: to assess the burden of violence in each context, to examine health consequences of violence, identify risk and protective factors, assess utilization of services, and to guide violence and prevention in HIV programs and policies as well. Next slide. As Leah had already mentioned, VACs is truly global and has been implemented across sub-Saharan African countries, Southeast Asia, Latin America, and Eastern Europe. And for the first time, VACs is being piloted here in the United States. Next slide. So the studies from the African countries, or 9 studies, could be grouped into 3 main themes based on the findings. One is prevalence and overlap of violence, and also the relationship between ACEs and health and behavioral outcomes as the second theme, and the third theme being ACEs measurement and methodology. Next slide. So to get into the findings, I want to talk about how ACEs were operationalized using the VACs data. So 6 ACE types, which are part of the broader VACs questionnaire, were included in this study, and they included childhood physical, sexual, and emotional violence, witnessing interparental violence, witnessing physical violence in the community, and orphanhood. These ACE items were measured using questions drawn from the ISPICAN Child Abuse Screening Tool Retrospective, the ICAS-R, and the Juvenile Victimization Questionnaire, the JVKO. Next slide. So for the overlap, the prevalence and overlap of violence, we saw that consistent with the prevalence of ACEs that has been reported in elsewhere, the prevalence of ACEs in the African regions were very consistently similar. We found 72% of females and 82% of males that had experienced at least one ACE. And then the most common form of ACE that was identified in these 5 countries were witnessing physical violence in the community. But as you can see here, the other forms of ACEs, their prevalence weren't trivial. They were also high as well. For example, physical violence was 37% in females and 50% in males. Sexual violence, 16% in females and 8% in males. One thing we also saw was ACEs tend to co-occur, and this is something that had been alluded to earlier on, where we found 28% of females and 40% of males having had experience and witness violence. Next slide, please. So for the relationship between ACEs and health and behavioral outcomes, these studies also observed association between ACEs and multiple risk-taking behaviors and health outcomes, including those listed here, such as sexual risk-taking behaviors like transactional sex, early sexual debut, cumulative HIV risk-taking behaviors, as well as mental health outcomes. Next slide, please. So just to continue the relationship, we also observed very complex relationships between ACEs and positive childhood experiences, and a number of indicators that were examined. And these are listed here. For example, we observed high parental monitoring was associated with increased odds of seeking post-violence services. Strong father-child relationship was associated with lower odds of service seeking, and so on and so forth. Next slide, please. And finally, in the third bucket, we looked at, those studies looked at ACEs methodology as well as measurement, and 2 studies fall into this bucket. One led by Anor and colleagues, and this study was looking at parental absence and how that may merit consideration as an ACE. So given the findings from other parts of the globe, Anor and colleagues examined parental absence, excluding orphanhood, as potential ACE. And what they found was that parental absence was associated with poor mental health and substance use, which are consistently associated with other conventional ACEs, over and beyond those that are explained by other ACEs as well. And they concluded that, within the African context, parental absence, besides orphanhood, may merit the consideration as an ACE. Gilbert and colleagues also explored 3 approaches of measuring childhood adversities based on previous studies using the VAX data. These 3 approaches that were examined were ACEs impact, ACEs exposure context, and ACEs score. And they found that ACEs context was the best fitting model for this data. However, each approach demonstrated significant association with poor mental health. This concludes the overview of the findings from the African studies. At this time, I'll transition the presentation to my colleague, Colbert.
Thank you, Dr. Anor, and thank you everyone for joining. My name is Colbert Brown. I'm a research fellow in the Division of Violence Prevention at the CDC, and I'll share the findings from the studies from Asia. Next slide, please. So the special issue features 2 papers from Asia, and both of those are studies from China that examine outcomes among college students who have had an adverse childhood experience. One of the papers adopted a longitudinal design, and it explores the mental health outcome associated with ACE exposure, as well as a protective factor against that negative mental health outcome. The other paper is a cross-sectional study that explores the distal factors of bedtime procrastination, which is a potential marker for behaviors that can negatively affect mental and physical health, as well as overall well-being. Next slide, please. So numerous studies have demonstrated a link between adverse childhood experiences and negative mental health outcomes. But there's a growing body of literature on factors that promote resilience and can protect against the negative mental health consequences of ACE exposure. And as such, Wang and colleagues, they conducted a longitudinal study to first examine the developmental trajectories of complex post-traumatic stress disorder symptoms among college students, and also to investigate the effect of self-compassion on the trajectory of complex post-traumatic stress disorder symptoms. Now, self-compassion has been identified in the literature to be a factor that can regulate emotions and also reduce stress responses. Next slide, please. So the data that they used in the study were obtained from a longitudinal investigation of mental health among college students. They used an internet snowball sampling method to recruit participants, and data were collected at 3 time points with a 3-month interval in between follow-ups. Now, there were 14 ACEs that were examined in this study, and the ACEs were assessed using the Chinese version of the revised ACE questionnaire, which showed good psychometric properties. Next slide, please. So the results of this study show that emotional abuse was the most common childhood adversity, with a little over 44% of the sample reported experiencing emotional abuse often or very often. Now, this finding differs from what we saw in sub-Saharan Africa, where emotional violence was the least prevalent ACE. Physical neglect, however, was found to be the least common childhood adversity among this sample of college students in China. The study also identified 3 distinct subgroups of complex post-traumatic stress disorder symptoms, and those subgroups were the low symptoms group, which majority of the sample was in, the moderate and high-risk groups. Self-compassion was also found to be protective against the development of complex post-traumatic stress disorder symptoms. It was found that high levels of self-compassion were significantly associated with lower odds of being in one of the more severe symptoms group. Next slide, please. So the second study in the special issue from China explores the distal factors of bedtime procrastination. Now, there are empirical studies that have shown that adverse childhood environments can increase unhealthy behaviors in adolescence and adulthood. And one of the unhealthy behaviors that is common among young people is bedtime procrastination. But there's evidence in the literature to suggest that life history strategy and sense of control can potentially mediate the relationship between environmental risk in childhood and bedtime procrastination. So Sheo and colleagues, they conducted a study to explore the relationship between two fundamental dimensions of childhood environmental risk and bedtime procrastination. They also examined the mechanism of life history strategy and sense of control as potential mediators in that relationship. Next slide, please. So that study was a cross-sectional design conducted among college students between the ages of 16 to 24 years old in China. So they used a convenient sampling strategy similar to the other study in the special issue from China to recruit the participants. Childhood environmental risk included dimensions of environmental harshness and environmental unpredictability. Environmental harshness was characterized by socioeconomic status of the neighborhood, school, and family, while environmental unpredictability was characterized by parental divorce, household moves, and parental employment changes. Next slide, please. So that study highlights a positive association between both harsh and unpredictable environments in childhood and bedtime procrastination. The findings revealed that life history strategy had a positive effect on sense of control, but sense of control had a negative effect on bedtime procrastination. The results show that there were two mediating paths between environmental risk in childhood and bedtime procrastination. And those were through the mediation of sense of control and the serial mediation of life history strategy and sense of control. Next slide, please. And I'll pass it over to Dr. Dubé, who will share findings from the Latin America studies. Thank you.
Thank you, Colvette. And it's a pleasure to be here and co-present with all of my colleagues here from CDC and NIH. So my segment is going to focus on the Latin America study findings. And within this special issue, across the 16 studies, we did have 5 that originated from Latin America. But just a little background as it relates to Latin America and some of the data that Pan American Health Organization has displayed on their website and provided to understand violence against children. Based on PAHO, an estimated 58% of children in Latin America experienced physical, sexual, and/or emotional abuse in the past year. In terms of sexual violence, specifically drawing from the VAX data, and these are children before 18 years of age, Honduras reports 16% of girls and 10% of boys experiencing sexual violence. Colombia, 15% of girls, 8% of boys. And El Salvador, 14% of girls and 3% of boys. And in terms of peer-to-peer bullying, 30% of students in South America were reported to be exposed. I think these data highlight that violence amongst children in Latin America is quite prevalent. So in Latin America studies that were highlighted in the special issue, there are 5 studies. 2 were from Mexico. Mexico is actually part of Central America, and then 1 in Colombia and 2 from Brazil. Just a little background in terms of the World Bank categorization or classification of these countries. They're all actually considered upper middle income economies. But one of the key things to understand is that middle income is split between low and upper, but they are still considered a part of middle income countries. But the important thing to understand across these countries is they all have significant socioeconomic inequality and poverty. And violence, as I mentioned, is very prevalent in Latin America and especially in Colombia. So I'm first going to go over the first two, the Mexico studies, the first two studies out of Mexico. And the first study, the purpose was of the study was to conduct a validation of the ACE International Questionnaire, or the ACE IQ, that many of you may be familiar with. And the second study purpose was to examine the associations between ACEs and mental health problems as predictors of suicidality. These two studies actually were from the same research group, utilizing the same data set. Both utilized 5,836 completed surveys. They were non-probability samples of students aged 11 to 19 years, with a mean age of 16, and predominantly more females than males. And what the first study highlights is that ACEs were very prevalent. Actually, the most common ACE reported was neglect, followed by community violence. Parental loss was actually the least frequent ACE. And across the total number of ACEs, that very blunt instrument, if you will, about 91% of the youth in this study reported at least one adversity. And then I want to highlight also, of the abuse categories, psychological abuse was most prevalent. And I think that's something we are seeing more and more across globally, across high, middle, and low income, is that emotional abuse, psychological abuse, verbal abuse is on the rise. In terms of the second study, looking at the associations or the contributions of ACEs and mental health problems as predictors of suicidality, I highlight, because the authors looked at both the combination of ACEs and mental health, but I'm highlighting specifically here the contribution of ACEs and the total number of ACEs to suicidality. And I want to just point out that in this study, it was interesting because from the CDC Kaiser study, we published the relationship between ACEs and adolescent suicidality, and these odds ratios are almost exactly the same as what we published over 20 years ago. The next study that we'll highlight is from Brazil. And the purpose of this study was, again, to examine prevalence and associated factors of ACEs among public university Brazilian students. It was, again, a non-probability sample, 546 university students with a mean age of 21 years and predominantly more female than male. And I'm again just providing the key study findings. Physical abuse was most commonly reported, followed by emotional abuse. 74% of the students reported at least one ACE, and 13 4 or more. One of the key findings from this study to highlight is that actually family income was strongly associated with reporting 4 or more. That is, students from low income families had a greater report of ACEs. And I think this, being in the educational system myself in higher ed, really there is attention needed to how educational systems can support students from low-income families, knowing that they have been exposed to multiple types of early stressors, which we know can impact learning and academic success. And then finally, the last two studies are from Brazil. I highlight the first study. The purpose of this study, Brazil study 1, the purpose of this study was to examine, I apologize. So this study was Brazil, and then the second Brazil study was to examine empathy as a protective factor amongst 1,229 boys and girls from public schools with high social vulnerability. They were 14 to 17 years and predominantly female. And what this study highlights as girls experience more ACEs in close relationships than boys, but boys experienced more physical abuse in this study. And another key finding was that empathy as a protective factor moderates the relationship between ACEs and psychological adjustment, which is not a surprise as we begin to really understand positive childhood experiences and how they can actually mitigate the negative impact of ACEs. But the study does highlight that the directionality depends on the context of where the ACEs occur. And now we get to the final study that was in Colombia. And the purpose of this study was to examine the association between youth violence and mental health outcomes in Colombian youth. This was actually utilizing the VAX data, the 2018 Columbia VAX data that Dr. Anor spoke about previously. It was a probability sample of 2705 youth, 13 to 24 years of age, with a mean age of 18.5 years. So I want to just remind us that all of us that this is representative of Columbia youth and young adults. And again, this key study findings, we found that actually female Colombian youth reported greater exposure to sexual and emotional violence, and physical violence was higher amongst Colombian males compared to females. And then another really important finding from this study, again, highlighting the fact that emotional abuse, emotional violence, verbal abuse is on the rise, is that compared to those youth that were not exposed to emotional violence, those who were had a higher odds of reporting suicidal thoughts, self-harm, and psychological distress. So just to highlight some of the key findings, based on these findings from Latin America, the prevalence of violence amongst youth and young adults is high. We found across the Latin America studies, 70% or higher of the youth and young adults reported some form of violence or adversity. There were gender differences observed for specific ACEs. However, what we want to highlight is that all youth and young adults experience high levels of ACEs. And we also did find strong associations between violence and ACEs with suicidality and mental health problems amongst youth and young adults, cross-validating other studies from the special issue, but most importantly, that cross-validating or validating what we've seen even in the adult populations. So I'll just give a few limitations of the studies overall from the special issue. Many of the studies did utilize samples of convenience, thereby the generalizability of the findings is not possible. And of course, many of the studies did use cross-sectional data, so we cannot make causal inferences. Now, another limitation is we did not receive papers from all LMICs in each of the 3 continents that were covered, and not from all of the LMICs in general across the world. So I'm going to turn it over back over to Dr. Gilbert for some closing comments.
All right, thank you, Shanta. These next few slides, I'm just going to go over some of the cross-cutting findings or themes that we noticed sort of were interwoven across the papers. Next slide. The first is just, what we probably knew and expected, but that the prevalence of ACEs is extremely high and it's unacceptably high, and it's alarming. Just looking at our samples from the papers in this special issue, the range was 70 to 90%. And the MNA paper, which included the 5 sub-Saharan African nations, 72% of females, 82% of males experienced at least one ACE. In the Casamuñoz, Mexico study, 90% of youth. In the Rizzo study, 74% of youth. And it's not just one ACE we're talking about here. So when we looked at cumulative childhood adversity or multiple ACEs experienced in our 5 sub-Saharan VAX studies, 20% of youth reported 3 or more ACEs. In a Brazilian sample, 13% 4 or more, and in the Mexican student sample, 30% or more. And it's not just that the prevalence is high, there's also some unique patterns noticed across genders that would be worth exploring further. Next slide. A second cross-cutting theme is that nearly all of the behavioral and mental health outcomes that were studied across these papers, almost all of them did have associations with childhood adversity. So just a refresher, some of the outcomes that were looked at were sexual and HIV risk behaviors, substance use, service seeking, psychological distress, suicidal ideation, suicidal attempt, and self-harm behaviors. And I put this image of the pyramid back up again because I think these behaviors that were studied, or mental health outcomes, are likely some of the things that kickstart youth on that downward trajectory that ultimately results in disease and disability and early mortality. So intervening in youth is really our key to interrupting these pathways that lead to poor outcomes down the road. A second point I wanted to make here is the important associations with mental health. 80% of suicides in the world occur in low and middle income countries, and suicide is the 4th leading cause of death globally in youth ages 15 to 29. So that means that interventions that respond to ACEs could be a life-saving effort in low and middle income countries, and we need to explore that further. Next slide. Another important finding across a few of the papers was the importance of emotional violence. So in the Vahedi paper, just a refresher, both males and females who experienced emotional violence had over 4 times the odds of ever reporting suicidal thoughts compared to youth who had not experienced emotional violence. And in my paper, parental emotional violence was found to be one of the highest impact ACEs for both males and females when looking at the outcome of mental distress. And I think it's really important to mention because emotional violence is one of the lesser studied ACEs, and for good reason, right? It's less physically obvious, it's very difficult to define, it's hard to create measures, and it's hard to intervene. It's hard to create legal protections against abusive language, for example. So even though it's hard to study, it's an important area of science that needs to be explored further because it's really impacting our youth. Next slide. Another important cross-cutting finding through our papers is that we might need to update what we consider to be standard ACEs. We know that community violence, while it has been studied as an ACE in multiple papers, it's not always on the typical ACE questionnaires. But witnessing physical violence in the community was the most prevalent ACE in the 5 sub-Saharan nations with pooled VAX data, and community violence was the 2nd most prevalent ACE among Mexican youth. So we know there are other types of ACEs that need to probably be what we consider to be the standard or the norm, and not just other studied ACEs, but also new ACEs or less studied ACEs. The NOR paper, for example, looked at parental separation not related to orphanhood for greater than 6 months, and it performed like an ACE. So I think looking at adversity in low and middle income countries opens the door to a much broader variety of adversity that we should be looking at. Next slide. So some of the future directions that I think come out of this special issue, while it was a great start at inviting studies involving youth and youth from low to middle income countries, there's still a lot of gaps that we need to explore. One of the first things that I think is a future direction is to enhance our overall surveillance of ACEs. The violence against children surveys are nationally representative samples, and I think they provide a great example of how countries can get nationally representative data. And if they choose to repeat a VAX, which some of them have, then they're starting to create surveillance of diversity in children. And so if more nations could adopt studies like this, we would have a broader picture of what the world's children are facing. Next bullet. I think another important direction is that we need to explore other forms of adversity, especially those that are maybe unique to low and middle income countries. So just some examples: institutionalization, harmful gender norms, child labor, child marriage, forced conscription into armies, political instability. There is such a broad range of adversity that occurs outside of the household context that we need to explore further. Next bullet. I would also love to see us developing more objective measures of what is considered an adversity. So what, with respect to disruption of biological systems, is considered an adversity? Instead of us trying to think of every single type of adverse experience out there and include it on a questionnaire, what if we had biological measures that tell us the stress load of what children are experiencing? This might make it easier to measure and standardize across nations with different cultural contexts. Next bullet. I would love to see us develop more a multidimensional characterization of cumulative childhood adversity. So right now, the standard is to sum the number of ACEs experienced, creating an ACE score. And this assumes that all ACEs are weighted equally and that each additional exposure applies a constant increase in risk. But if we could develop measures that incorporate impact, frequency, severity, et cetera, we might have a broader understanding of what cumulative childhood adversity looks like. Next slide. I think these papers pointed out many of the samples resided in households or were attending universities or schools, and we need broader populations of youth included in studies. We know that youth who are homeless, youth that reside in institutions, youth that might be incarcerated or in captivity are certainly experiencing the burden of adversity, but they're harder to get to. So I think a future direction is how can we include youth in multiple settings and not just those that are the most easily accessible. Next bullet. Another future direction for ACEs research is expanding our understanding of resilience. We saw in a couple of these papers some of the positive childhood experiences or resilience factors that help to mitigate the impact of ACEs. And I think in low and middle income countries, we probably have a lot to learn from other forms of resilience that might buffer ACEs in general. So while we've tended to focus on adversity, looking at what can buffer those outcomes is an important direction down the road. And next bullet. And finally, most important is how do we establish, disseminate, and make universally accessible evidence-based practice that primarily prevents ACEs or at least reduces the harms of ACEs at the earliest point possible in a child's developmental trajectory. We've started to do this. The WHO Inspire Technical Package includes evidence-based practices that have been implemented in low resource settings, but we really need to build our knowledge on what works and how to make it accessible to everyone. Next slide. And with that, I thank you all so much for listening to our summary of the papers that were included in the special issue. And now we will move on to questions and answers in our panel discussion. Thank you.
Perfect. Thank you, Leah. Thank you to all our presenters. There is such depth of information that was just presented. So I know we have lots of questions, but I want to introduce you to some guest panelists who are joining us today, and our sincere gratitude for them being willing to donate their time. So our first panelist is Dr. Greta Massetti. Greta Massetti is the Principal Deputy Director of the CDC's National Center for Injury Prevention and Control. In this role, Dr. Massetti oversees the center's surveillance, epidemiology, data science, and public health programmatic efforts to expand and refine the CDC's capacity to prevent all forms of injury and violence. Dr. Massetti's leadership for NCIPC's center priorities include drug overdose, suicide prevention, and adverse childhood experiences. And our next guest panelist, Dr. Phyllis Holditch-Nylon. Dr. Nylon is a senior advisor for adverse childhood experiences in the Office of the Director of the Division of Violence Prevention at the CDC's National Center for Injury Prevention and Control. In this role, Phyllis coordinates the DVP's work relating to the prevention of ACEs and collaborates with both internal and external partners on advancing the field of ACEs prevention and response. Phyllis co-authored the Center's first ever research priorities for ACEs and is the lead author of the division's resource, Intimate Partner Violence Prevention Resource for Action. And also joining us today, Pedro Manuel. Pedro Manuel is a surveillance specialist with over 15 years of experience dedicated to public health research and surveillance, particularly in HIV/AIDS, tuberculosis, malaria, and neglected tropical disease. In the past 7 years, he's been working in HIV surveillance within the CDC office in Mozambique. And during this time, he's been supporting and assisting MOH, National Institute of Health, and participating partners and government agencies on designing, implementing, and strengthening routine disease surveillance systems. Pedro was involved in implementing the first VAX survey in Mozambique, biobehavioral surveys among key populations, and health and demographic surveillance and mortality. So thank you to our additional panel members who will be joining us for the Q&A. So I'm going to start, I'm inviting all of our presenters and panelists to turn their cameras on and their mics, and then we will get to some questions. Some came directly to me, so I may go through a few of those as we open the Q&A. There was a question about, and this, whoever feels compelled to answer, please feel free. These are a few of these are more global questions, but there was a question about terminology, and if in fact the distinguishing factors between emotional violence, verbal abuse, and psychological abuse. Those terms were used differently depending on the surveys, and was curious of the difference, or if we are, you know, how would you define those differently and why they were measured differently in different surveys?
I'd like to go ahead and take a beginning crack at it and then, open it up to everyone else. This is just because of recent research that I've published around childhood verbal abuse and some of the advocacy work in that space. And right now, as it stands, verbal abuse is not a form of child maltreatment. Emotional abuse is recognized as one of the 4 forms. And one of the key pieces around that is if you look at some of the measures of emotional abuse, they do include adult speech behaviors towards children, which would then translate to verbal abuse. That is not to minimize emotional abuse or psychological abuse. They can come in various forms. And I will also say research has shown that, and there is an area where even witnessing domestic violence, children witnessing domestic violence can be a form of psychological abuse. So I hope that kind of helps to lay a little bit of what we understand about emotional abuse. And I want to also just say, when we talk about emotional abuse, it's really what happens to the kids. It's what they suffer. Versus when we talk about verbal abuse, it's the behaviors of the parents towards the kid, or the adults towards the kids. So I'll stop there and let one of my colleagues further chime in.
I might just jump in a little bit just to build on that. You know, I do think that there's, to some extent, those distinctions are labeling distinctions and not always measurement distinctions. So when you look at kind of how questions are structured in different studies, the way emotional violence is measured looks very similar to the way psychological violence or psychological abuse is measured and the way verbal abuse is measured. So they're probably in many studies measuring the same thing. They're just different fields or different investigators use different terminology. In the violence against children and youth surveys, we tend to use emotional violence just to be consistent with what has been established in the field, but it does include measurements of psychological abuse as a component of that. But yeah, I mean, I think that's just a reflection of the fact that there aren't always standard agreements around which language we use. And so I would encourage, if you're interested in thinking like, oh, is this actually the same thing? It comes down to the question. I don't know, Phyllis, if you had anything to add about that.
No, I agree with Greta. I mean, I feel like I feel like generally those terms, while maybe not used interchangeably by researchers, do sort of cover the same broad subset of behaviors, although sometimes distinctions are made. Whereas, like Shanta was saying, like verbal abuse is name calling and sort of adults using put downs or humiliating comments, but a lot of that type of behavior is also captured in other definitions of psychological abuse and emotional violence, emotional abuse.
Perfect, thank you. Would anyone else like to add anything? The same question came up a bit about parental absence versus parental separation. Are those seen as two different types of ACEs, or is that a semantic issue as well?
Yeah, I can start with that as I led that study. Yeah, so we are looking at different things, and we are very intentional about looking at this parental absence, which is a little different from parental separation. It could include parental separation, but it's sort of like more broader than parental separation, and also orphanhood, because technically orphanhood is also parental absence or sort of separation, right? The parents is no longer there. But for the study that we looked at this parental absence, we included other kind of measures, including the parents may still be married, but parent may have moved away due to some reasons, or child has moved away for other reasons. So in other words, the parental separation, which usually, separation, which could encompass some of these things, and usually in the context of like separation, like not divorce, but like parents don't live together anymore, things like that, for so many reasons. For the VACs, what we measured here were to capture some of those separations, but as a result of in the context of parents moving away or child moving away from parents due to, say, work or school or some other forms. And in some instances, I think people may be using the same terminology to mean what we use here, but for the VAX purposes, we use this to just, we were very intentional, and we use this to just mean parental absence for 6 months or more due to some of these reasons. Now, one thing also to mention here is in some instances where parental separation has been used, the time component is also different from what we use here in VAX, which is, again, the 6-month timeline. In some cases, it could be few months or years, but for the VAX, it was just 6 months or more, and we didn't distinguish between whether the parents returned or whatever it is in that case. I'll see if I just want to add anything to that. Oh, and by the way, we did not include orphanhood in this definition. Those were excluded from the definition of parental absence in our study.
So children in out-of-home settings were not part of the VAX survey. Is that what I'm hearing you say? Kids in orphanages and?
Yes, they are.
Okay.
They are not part of the VAX. Only this is a household survey, and so only those who reside in homes were included.
Right, and that refers to children who are currently living in orphanages. Now, because VAX covers from ages 13 to 24, there may be a number of individuals who are living in households who were formerly in orphanages or had been living in other institutional settings. So that's one of the benefits of having a broader age range is it may not include individuals that are currently in institution, but that had been in institutions in the past. And so it does cover those experiences retrospectively.
Perfect. Thank you. Now, speaking of the age range, it looked like most of the VAX surveys were 13 to 24. Colvette, you covered college students, right? In those studies, the 16 to 24-year-olds. Is there a reason why that age group was done differently in the Asia surveys?
So thank you, Jane. So the Asia survey is, focused on college students. And I think one of the reasons is because at that pivotal point in development, college students face a lot of, mental health problems, psychological problems that they wanted to examine specifically. And again, that study, unlike VAX, utilized a convenience sample. VAX data are representative sample. So yeah, I think it was just the fact that at that pivotal time in the life of those, students at that time, they wanted to explore how ACEs affect the mental health among those students.
Perfect, thank you. And then while we're on this topic, I know that you covered post-traumatic stress disorders in this sampling, but what is CPTSD? Is that
So-
complex post-traumatic stress disorder, and what are those? What's the difference?
Yeah, so CPTSD stands for complex post-traumatic stress disorder symptoms, and it is a mental illness like PTSD, but it's a little bit more severe. It includes symptoms of PTSD plus additional symptoms such as affect dysregulation, negative self-perception, as well as difficulties, in relationship, among others. Now, CPTSD results from sustained, repetitive, multiple exposures to trauma. PTSD can result from a single exposure to trauma. So I think that's the main difference. And CPTSD does result in more severe impairments to psychosocial functions.
Thank you. And Pedro, I know you were involved in the Mozambique studies. I'm curious, the results of those studies versus the rest of the African studies, was there a difference in prevalence or a different in results that came out of that particular study?
Good afternoon. Thanks, Jen, for your question. Yes, I was involved on the VAC study in Mozambique, and also from what we have say here during this presentation. There's a lot of things that are common, basically, in African countries, all the emotional and sexual violence, they are really common in Africa. And the ACEs prevalence that we saw here is really high. And I am even knowing that all of those studies, they have used a kind of a pooled, data from different African countries. I do believe that separately, we will also see a high prevalence of ACS in Africa, and particularly in Mozambique as well.
Thank you, Pedro. And perhaps this is the time to talk about the prevalence. 70 to 90%, Leah, is what I think I heard in your slides. So I'm curious, was there a level of shock about the prevalence number? Is it what you expected based on everything we know? And this was prevalence kind of as an overview. Obviously, it was different based on some of the surveys, but I'm curious in all of your opinions on prevalence. Obviously, it's shocking as an audience, but where you felt when the research landed, the results.
I think for prevalence of experience, at least one ACE, I was less shocked, but some of the more cumulative experiences. So I presented also those reporting 3 or 4 or 5 or more ACEs was higher than I was expecting, because it's really this, I think most of us in our life have experienced some form of trauma at one point or another, but the accumulation of these experiences over time is really where we see the biggest health impact changes. So I think it was a little bit more alarming to me seeing some of the cumulative numbers. But yeah, generally speaking, there was some higher general prevalence than I've seen in some other studies from developed nations. So, and we're not even covering every type of adversity out there, right? Just the ones that were measured in these particular surveys. So it just tells you how much more kids are experiencing than we even know about.
And that was telling to me as well, that you also listed multiple ACEs that haven't been measured yet that are opportunities to measure. And, with that prevalence already so high, it is, it is alarming. Does anyone else have a comment about prevalence or anything you want to add about that?
Yeah, I think it's just in terms of reflecting on the complexity of comparing across countries. I think one of the real benefits of this special issue is the fact that it really reflects data from low and middle income countries, because so much research and data collection has been conducted in high income countries in the US and in Europe, particularly the UK. And so being able to kind of really use those data to generalize to low and middle income country doesn't always translate. But also there's so much nuance in measurement and definition. And so using a data source like the Violence Against Children and Youth surveys, the measurement, the way the questions are worded, what we count as an ACE is consistent across surveys. So we're able to say, are the data from, say, Colombia or Honduras relatively similar to or different from sub-Saharan Africa or other places where there has been a vax data collection? So, the prevalence in some studies in the US and the UK, for example, are a little bit lower than what we're seeing through vax, but some studies are higher or similar. And I think that just speaks to kind of the need to have standardized definitions and measurement for ACEs, so that maybe not every country does a vax, but if we use consistent approaches to kind of questionnaire development and implementation, then we can kind of get to a little bit better consistency, so we understand. So it's not just kind of our reaction to the prevalence, but it's also the caution against interpretation, because some of it is just methodological. So Phyllis, I'm sure you have lots of opinions about this as well.
Yeah, I just wanted to build on that a little bit. Certainly in the United States, in terms of nationally representative data, we don't have data that is collected from adolescents that is national yet. We were able to add some questions to our National Youth Risk Behavior Survey in 2023, and that data will be released and published later this year. But that's going to give us the first ever kind of national estimates in the United States among U.S. high school students of 8 ACEs that align pretty well with the originally studied ACEs in the original CDC Kaiser study. We published last year our first time of having data from adults from our behavioral risk factor surveillance summaries across all 50 states. It's the first time we had data from all 50 states and territories, estimating sort of ACEs state by state among adults. But as Leah pointed out in her kind of opening remarks, just having data on ACEs from adults who are kind of being asked to retrospectively remember what happened to them has a number of biases. So the vax data is really, really exciting, and we are trying to move at CDC in the direction of collecting data from youth, from self-report, so that we have a better sense of how prevalent data is in the US. We have another study, the National Survey of Children's Health, and that asks parents about children's experiences, but it doesn't include the ACEs of child abuse and neglect. It just has information on kind of the household challenge ACEs. So right now we don't really have complete data even to give accurate estimates nationally of prevalence among youth, self-reported by youth in the US. And VAX is really kind of on the front and cutting edge, and these other studies that were presented today in that way.
Thank you for
Yes,
that. Well, go ahead, Peter.
Yeah, no, I just wanted to add and say that I can speak on the context of Africa, but oops.
We can hear you, Pedro.
Yeah.
Can you hear me, please?
Yes, we can
Yes.
hear you very well.
Okay, but I can't see you guys. I don't know what's happening here. So I was saying that I can speak in the context of Africa, but let me just provide like a kind of example from Mozambique. We know that studies on children and youth and also related with violence, it's limited in Mozambique, even in Africa, you know. But you know, based on what was presented here, and also the personal opportunity that I had to work with the VAX team, and more recently on this all HCS issues, HCS issues, I think it's important to emphasize that for us, at least, you know, the VAX data, they are crucial for the countries. It contains a lot of information, you know, that the country can use even to develop their own programs to respond to the violence problems, and basically also to align that with the adverse child youth experience, and how also the countries can prevent that.
Perfect, thank you. That kind of goes with the question from the Q&A as well, that the difficulty potentially to use ACEs in countries like Africa, because they're more developed country standards. Like, do you find that to be true in what we're trying to measure in the VAX surveys? Like, are they developed country standards that we are in fact trying to measure in?
I think I can start. So I think, well, so the VAX, and as I said, those ACEs measures that were included in these studies from the VAX at least were from validated kind of tools, including the ICAS-R, for example. And we have consistently implemented the VAX in multiple countries. And we have been learning from the VAX about how these measures are doing. So we go through extensive adaptation process to make sure that the questions are relevant in the context that we're asking them, and we're asking them in an appropriate way. So I think for, at least from the VAX standpoint, the measures that we have measured or included in the ACEs are things that don't reflect what has been happening, or measures from developed countries. These are measures that were developed tailored to these kind of specific contexts. In addition to that, I think one of the main reasons why we were interested in looking at expanding the ACEs within the African context was some of these kind of feedback that, and then potential limitations, which is, you know, in the African context. So when you come to the US or other developed countries, we are talking about parental incarcerations and things like that, which are all adverse childhood experiences. That is not so common in a lot of African countries. So what other kind of exposures related to parental absence may impact some of these health outcomes? And that is why we started to tease apart, like, within the African context, does parental absence also matter? Does that have impact on long-term well-being of these children, and so on and so forth? So I think the measures that we have, again, are not just developed country measures. For VAX, at least, I think others can speak to other studies and other data sources and how those measures were developed. But for VAX, we have used these tools and measures consistently, and we've been gathering information about they are relevant to those contexts and whether we are measuring things that we feel like is really important to these communities. Greta, maybe you want to add something to that, because you've been part of VAX for a long time.
Yeah, I mean, I think there's a couple of pieces in terms of, in addition to the adaptation process, I want to speak to the importance of using validated and consistent measurement and definition. So the way that ACEs are defined in the Violence Against Children and Youth surveys, those questionnaires, they rely on surveys and instruments that have been used in other contexts, in other studies, so that when we are talking about physical violence, we are saying what we're describing is the same thing as another study that maybe uses slightly different methodology, but the same measurement, and that's or in a slightly different context. So I think that's really important, is, in terms of advancing the field, is kind of ensuring that we have definitions and measurement tools that can apply across contexts. So for example, the way we measure heart disease and COVID, those, like, having those standard definitions means that, like, COVID in Denmark is a different disease than COVID in the United States or COVID in Mozambique. And so the same should be true of ACEs and other forms of violence against young people. So that's, I think that's a really important piece. And then the other piece is kind of, especially in measurement of violence, of all forms of violence, using behavioral definitions in measurement, describing exactly, not asking questions like, have you ever been sexually abused, which may mean different things to different people or different things in different contexts, but having a very clear description of the behavior and experience that way, and knowing that those are things, physically forced sex is rape. And so whether it's, we use different labels in different countries, the fact that we're describing it as physically forced sex is a form of sexual violence and that is measured consistently across contexts. I think that that's really also helps us get a little bit better consistency across studies and across contexts.
So the VAC surveys do have those definitions.
That's correct. Yeah. And again, I think Francis's presentation mentioned that in the beginning. They're also consistent with, the ISPCAN measures, the NATSCEV measures, the JVQ. So they're not just things that we came up with out of our heads, but they're consistent with measurement tools that have been used in other surveys. And that's something, from a public health standpoint, when we're thinking about surveillance and measurement, we're always trying to rely on things that have, proven applicability across contexts.
Perfect. Thank you. I do have a question that is actually for Leah, but anyone obviously can chime in as well. But it talked about using, like, could ACEs ever have a weighted system, meaning parental absence? What if it's for employment versus incarceration versus, other more traumatic things to a family unit? Like, is there a weighting system for any of these ACEs that we measure for their causal relationship to the child?
Yeah, I think when we're looking at population level data or your whole sample level data, we can look more at the impact of various ACEs across the population being studied. But I think weighting individually would be pretty difficult, just because different adversities affect different individuals differently, right? How important parental divorce was to me in my childhood might look very different. Maybe it was a healthy change in your childhood, right? So I think at the individual level, weighting various ACEs or giving more weight to certain ACEs than others would be difficult to do. But we did sort of try to look at this in our study that's in this special issue, looking at the overall big picture impact, like which of the ACEs had a higher impact on the health outcome we were looking at was mental distress. So this would vary by outcome you're looking at as well. So we did take a look at which ACEs had the most effect on mental distress as compared to others. And that's where we found the emotional violence finding that I mentioned earlier. But I think making it a sort of a standard process, like this ACE weighs more than that ACE, I think would be too difficult because of the individual experience and the context around the adversity.
Thank you. Anyone else like to comment on that?
Well, I'll just say quickly that I feel like we at CDC and our partners in the field have certainly identified better understanding of chronicity and frequency and severity of certain ACEs, and really understanding the impact of that is a gap in the research and an area where we need better research. I agree with Leah that at the individual level, it would be very difficult to weight certain experiences because it depends so much on individual experiences and context and everything else. I'll mention briefly that we are working on developing. Division of Violence Prevention has developed other kind of uniform definitions of child abuse and neglect and sexual violence and other definitions. And now we're working on developing uniform definitions of adverse childhood experiences and positive childhood experiences. And when we've developed other definitions in the past, they've been primarily kind of for our use at CDC. We're not kind of pushing them on the rest of the world, but we do publish them, and they are frequently used by our partners and others kind of domestically and around the globe. So we hope that this is going to be really helpful. And what we're trying to do in that process is really understand kind of the underlying trauma that is related to certain adverse childhood experiences. I don't think anyone, we or anyone else, is ever going to be able to come up with sort of an exhaustive list of all the different potentially traumatic experiences that children can experience, and especially in different contexts and different incomes and socioeconomic strata, et cetera. But to identify sort of the underlying trauma of being separated from a nurturing parent or caregiver that could show up in what Francis was talking about parental absence, right? It could be a long deployment of a parent who is serving in the military, or it could be through an asylum or refugee situation, right? But it's the sort of the underlying trauma of being separated from that parent or caregiver that is the underlying trauma, and then many different specific adverse childhood experiences could fall within that underlying trauma. So we're hoping to release those uniform definitions either late this year or early next year.
Well, I think that'd be very helpful. So I'd like to focus now on, so you have these great studies. A special issue highlights, some really impactful VAX results, and these, studies from three incredibly different countries with a level of cross-cutting themes, which I think really do speak to the consistent critical need for these studies, for this data. But where do we go from here? So beyond data, how can it be taken to action, into something really tangible, whether it's policy change, whether it's program creation? Like, where do you see the data going to action? And I would love to hear from all of you.
I might start, but I really would love Pedro to perhaps give us some examples of how things have really evolved in Mozambique in particular, as an example. So, data are only valuable insofar as they shed light on the nature of a problem and help us point the way towards solutions. And that is really something that's essential to the violence against children and youth surveys. Other data collection systems have a similar intent, but part of what Francis described as the adaptation process to VAX is about building country leadership and country commitments to not just the survey itself, but we're committed to doing something about these results. We're committed to shedding light on this problem and holding ourselves accountable as a government, as a country, as leadership to really take action given the results. So that's an essential component to ensuring that data collection effort is successful. The other piece is making sure that the data that we collect provide actionable insights. So it's not just like, okay, we're measuring the problem. What does that mean? What do we do about it? So as part of VAX, we build in and embed in our process a data to action series of engagements that really provide supports to governments in interpreting the results and gleaning insights, and then really informing kind of government action through kind of a resource that called Inspire 7 Strategies for End Violence Against Children that was co-led and released by the World Health Organization and CDC. That's really kind of the best practices, all of the things that you think governments ought to do to create thriving and beneficial conditions for children, like implementation and enforcement of laws and changing social norms that are supportive of violence and supporting parents and caregivers in education and so on and so forth. And so those give us kind of the VAX and Inspire give us kind of the essential tools to provide support to walk through from data into action. And maybe Pedro can give us some insights on how things have worked in Mozambique and how this process has been embedded into their government programs.
Yes, thank you, Greta. Yeah, so this is actually starting from the ACEs results here, and also talking a little bit about what the country will do. I think this is the largest study of ACEs in children's and young people ever presented. And I also think that these results separately, they reflect the challenges that many countries in Africa, including Mozambique, are facing. And things like when we talk about Africa, socioeconomic factors, most of the time, they worsen the exposure to violence. So I believe that different countries will translate, or they have already translated those findings into concrete actions. As Greta mentioned here, one of the positive and interesting thing that VAX does after the results are available is to hold a data action workshop in the countries. This workshop is a kind of multi-sectorial workshop with the objective to help the stakeholders to translate the VAX data into prioritized and actionable next step. Mozambique was one of the countries which benefited with this data to action workshop. And many things have happened, after that. Just to review a kind of small, summary of that. We do have the kind of immediate actions and responses that have already, happened. And one of the biggest things that the country was able to do is to develop a national action plan for children. And this plan is kind of high-level document which is approved by the Council of the Minister, and it contains a lot of actions that different sectors will implement to reduce violence in the country. So I'm assuming that with plus all of this ACS result and emphasis that we are bringing here, countries will be able even to update their plans to come up with more actions and include also actions that are related to reduce, ACS in the countries. So it's basically a small example of what is happening. We have a lot of things that is going on in the countries, but the biggest thing that we want to emphasize here is the National Action Plan for Children, which will help the country to reduce violence and consequently also reduce childhood experience.
Thank you, Pedro. It sounds like there's a great opportunity to create guidelines on the formation of national action plans. It sounds like what you did in Mozambique is very powerful and very tangible from the results of the back survey. Does anyone else have, like Shanta, do any other examples of potentially like something like Inspire or a national action plan that can take this data to action as well?
So not a national or even a country level but actually I just want to speak to some of the work at the local level. So we had several studies that were in university students. We're actually conducting our own study at Wingate to look at the impact of ACEs on academic outcomes, because we do see some academic concerns with learning, disengagement, and we believe it's largely due to, if you will, adversity. So I think it's important, even in the context of some of the non-probability samples, of how that data can act, because Greta said it very eloquently, that the data is basically very important in telling, and it can lead to action. But even at a local level, it is very telling and helps to inform what we can do. And I'm actually now in a academic institute, and I see how ACEs can actually impact students I work with. And so, kind of that practicality around the research and the science is really critical. And I also say I'm leading work with Union County in North Carolina around their opioid settlement. And North Carolina has been very strategic in ensuring that ACEs and trauma-informed care is integrated into the local, if you will, strategic plans around this. So I do think even at a local level, this information is very informative and can actually lead to more local level frameworks and programs and policies.
That is perfect. Thank you. Leah, Colvette, Francis, anything you've seen coming out of these studies?
I mean, I think this is something I encourage with every grantee that reaches out to me at National Institutes of Health, is to start your process with how are people going to use my findings. So to not even launch into your work until you've thought about who is the end user of this information, how can they take it to the community and apply it. So I think there's a lot of responsibility on researchers to ask those questions before they develop their study, instead of just, this is interesting, I'd like to publish it. Who's going to use it? How can they use it? Which population could be affected? And start thinking about how to make your study actionable at the end.
Yeah, and I think part of this has already been said by Greta, for example. I think what is happening here is the data and the kind of partnership and stakeholders engagement resulting in folks understanding the problem, but also knowing who is working on what. So for example, this data to action, when we go into some of these countries, the first time some of these organizations in the same country coming together to know who is working on what is when we bring them together, right? So I think this kind of data to action brings together these people who are going to build this kind of lasting relationship and know who to call when they need to work on this issue. I think one other thing we are seeing from the data is where the gaps are. Resilience is a huge thing that Leah had already mentioned and alluded to. What are the resilience factors in Africa, for example? How can we really build on this? How can we identify programs and policies that can address that. And we are seeing this, and these are being driven by the current data we have, because we know where the gaps are and we know what to look for, and so on and so forth. So I think the data is sparing some actions in multiple ways, whether it's policy, identification of the next steps, and so on and so forth, or to really help out with identifying interventions and programs that will address the issues that we are finding from the data.
Yeah, and I think there's still a lot that we don't know about ACEs, or that we don't know enough about. But there's one cross-cutting theme that we saw. We saw really strong associations between ACEs and negative mental health outcomes, and that was across all the 3 regions. We saw it in the African studies, we saw it from a study in China, we saw it in a Latin American study. The focus is always primary prevention of ACEs, but if ACEs do occur, we need to know the factors that can mitigate the consequences of ACE exposure. So we're seeing that there are some factors that can promote resilience. So moving the data that we're seeing towards action around building more body of evidence around resilience and intervention strategies that focus on improving, those buffering effects, those factors that can buffer against negative consequences of ACEs would be crucial with moving forward.
And then also, I'll just add to that, there's a very well stated, Colvette. Several of the studies also highlighted the importance of reducing stigma related to mental health. That is a major problem even in LMICs, and that these findings would help to really help in that area.
That's perfect. I know, Colvette, it kind of reminds me during your presentation where you talked about the effects of self-compassion as an intervention strategy on suicide rates. I mean, just that parallel was so evident. And I think, to your point, of whether it's policy change, whether it's, moving government intervention, or whether it's simply, treatment and intervention strategies at the local level, at the child level. So very child-centered approaches. So I think it all is a great response to the data that you're getting. I know I saw a couple things go in the chat that I wanted to let you know that I will be putting on the host page with this webinar recording, like the Inspire technical package. Thank you for the link to that. The data to action from Together for Girls. Again, we're all stronger together. So if there's any additional resources from the CDC or anywhere else, the National Institute of Health, that you believe would be of value to anyone accessing this recording, please send me the links, and that would be to our participants as well in the audience. I would love to get them all centralized on the page with this webinar, so it would be easy access for anyone. And then, so I kind of like to end on, Greta and Phyllis, maybe speaking to, we talked about how you take data to action, but even from a research perspective, where do we go from here? Like, what do you see as next steps? This is one special issue covering, 3 countries. So I'm kind of curious, 3 regions, I should say. So I'm curious where you would like to see the next steps, even for the research to happen.
I think there's this, one thing I want to comment on is that there's this interesting paradox about gaps in data and research. One is that there had been so much research in the last 40 years on ACEs in high-income countries, particularly Western high-income countries, particularly the US and the United Kingdom. And relatively very little that had been published in the research literature on ACEs in low and mid-income countries. So that was kind of the major added value of this special issue, is really filling those gaps. But then, as Phyllis mentioned, in terms of nationally representative data measured from young people, so it's not ACEs experienced 40 years ago, it's ACEs experienced last month or a couple of years ago that are more actionable. In terms of comprehensive coverage of all ACEs, these countries that have conducted a violence against children and youth survey have a tremendous added value over the United States, United Kingdoms, and others that don't have nationally representative data. And so this is a tremendous resource that I think this special issue has leveraged and really shown a light on the availability and the value of these data. In terms of kind of where to go from here, I think kind of awareness that these data are available and being able to leverage them for to fill additional research gaps is really important. So that's one piece. Another piece is, filling additional data gaps. There are countries that have not conducted surveys. There are opportunities for us to use these measurement approaches and say, can we get, if not the same exact surveys, but the same systematic methodology for definitions and measurements, so we can start to understand what the world looks like as far as ACEs, and then how do we turn these data into actionable models? So those are just some thoughts that turn it to Phyllis.
Yeah,
Thank
thanks,
you.
Greta. I mean, I think I would just add that that at CDC, kind of domestically, with ACEs, we are taking a science and data to action framework, kind of across everything we do. We have our kind of flagship programmatic work is our Essentials for Childhood Preventing ACEs through Data to Action, which is just in its first of 5 years of funding right now, but we're really trying to work with organizations who are within states. We also have a recipient who's a nationally recognized tribe among our 12 recipients. We're trying to really help them better understand how to collect data on ACEs and positive childhood experiences, to kind of speak to what Francis and Colette were saying of studying kind of these positive childhood experiences that can help prevent ACEs and mitigate their consequences when they've already happened. And then using our kind of strategies based on the best available evidence for preventing ACEs, which are in our Preventing ACEs Resource for Action, which I dropped in the chat, to take that data about sort of where the burden of ACEs is in their states and communities, and using that data to inform the prevention strategies and sort of where and how they implement those prevention strategies within their state. And I'll say that the violence against children surveys are kind of an amazing success story on this kind of science and data to action framework, right? That there are countries that have done the VAX and then used that data, of course, to take the Inspire technical package and use that information to implement prevention strategies within their countries. And then for those that are collecting a second VAX, able to look at the effect that the implementation of these strategies has had. So I think kind of domestically in the US, those are two major directions that we have, as using this science and data to action framework, really looking at positive childhood experiences and promoting those experiences, as well as how to best prevent ACEs, and then further research always, right, on what works to prevent ACEs and to promote positive childhood experiences, and in a number of different contexts.
And I'm assuming that would, could evolve to include parental, training guides and, creating a positive home life or a positive, community for these kids as well. I mean, really practical on that level.
Yeah, I mean, we really emphasize that sort of everybody in society, that we all have a role to play in preventing ACEs and promoting positive childhood experiences, and that we don't want to put that burden only on parents and caregivers, but sort of what can all of us do in the healthcare sector and policy, et cetera, to support families and caregivers so that we're supporting families in preventing ACEs and promoting positive childhood experiences. We do have some resources for parents and a brand new page at cdc.gov for parents, which I'll drop in the chat, that have sort of everything from developmental milestones, et cetera, to our Essentials for Parenting Toddlers and Preschoolers and our Essentials for Parenting Teens resources. So we do have resources for that, but we also want to emphasize that everybody has a role to play. It's not all, the burden shouldn't all be on parents and caregivers to do it themselves.
Thank you. Well, I know that we are past time. I appreciate you staying online, all of you. I think the conversation could probably continue for hours, but I can't tell you how much we appreciate the special issue itself, the research that was behind it, our four presenters and our three guest editors again, and for the three of you joining as a panel. I think that really speaks to your commitment to, to the VAC survey, the collection of data, the movement forward. On these issues that are impacting kids and the impact of ACEs. So my thank you to all of you. I will be sending out a follow-up email with this recording, access to the recording, and I'm trying to pop as much out of the chat as I can. I may reach out to the 7 of you as well to see if there's any additional links that I can put on that page. But we did have over 90 countries represented in the audience, so in the registration. So that was very exciting. I think you've touched some pretty large geographic areas today with your knowledge and expertise. So thank you to all of you, sincerely. And good morning or evening or night, wherever you may be, for our audience members. And thank you for joining us today. Thank you, everyone.
Thank you.